a really big welcome. And so our topic today is really around promoting smoking cessation among different populations and in its various guises. So we're really pleased to welcome some fantastic speakers. You're in for a real treat today. And just to mention, we've got our hashtag there. So if people could tweet to Fuse QRM, that would be brilliant today. And just raise that profile and be good to get the message out. The event will be recorded, is being recorded, and it will be available online later. So just to let you know, and the slides will be available later too. So is it possible to have the next slide, please, Cheryl? So our keynote speaker today is Jane Coyne, and she'll be drawing on work based in Greater Manchester, followed by 3 presentations based on research being undertaken in the Northeast region. So we'll be talking about characteristics of populations of smokers who are least likely to quit or to sustain that quit. For example, those living in impoverished circumstances, living with poor mental health, homelessness, who then find themselves receiving healthcare due to illness or pregnancy. So the presentations are based on 3 studies that are looking at these issues from different perspectives, actually, the service user, the healthcare professional and the commissioner. So we'll have a short Q&A session after the presentations to ask questions of the speakers, followed by a 5-minute comfort break before the discussion. Cheryl, could I have the next slide, please? Brilliant. So just a reminder, I can see people have got are muted and have got their videos off. That's great. So hopefully we can have a good internet connection. Please, can I encourage you to type your questions in the chat while the presentations are going on, because we want to pick those up in the Q&A. So I'd really encourage you to do that. Just be professional, and any concerns, if you just message one of the hosts or co-hosts, that'd be great. So thanks very much. Could I have the next slide, please? Just for anyone not familiar with Fuse, it's a key player in drawing together public health research in the Northeast and translating it into action. So please check out the website if you want any more information or contacts. Next slide, please, Cheryl. So at this point, I'd really like to hand over to Jane. She is a real expert in stop smoking in maternity and more recently broadening her role to other populations. Her job title seems to change on a regular basis, as do the number of hats she wears within maternity and tobacco control arenas, and no doubt many others as well. So just really welcome you here today, Jane. If I can hand over to you, that would be lovely.
Of course, thank you. So you've got me in a nutshell there. Many hats, many different talents, of master of none, I would say. Yeah, obviously in Greater Manchester, you can go to my first slide if you like. Just so you know a bit of my background, I've been a midwife for 20 years, in the latter half of my career managing community services and supporting those who have complex health and social needs. So obviously when I took this role on, it was really important that I really wanted to make a difference for those groups that obviously we're seeing even more been affected by the pandemic as we move forward. I came into GM in 2018, February 2018, and obviously took over the Smokefree Pregnancy programme. And that was really established in the response to the Saving Babies' Lives document that came out, and obviously wanting to reduce our stillbirths, but also seeing that our probably smoking at time of delivery rate wasn't dropping to the degree we wanted to see, and obviously knowing that we had some ways to go to meet that 6% criteria, you know, that national ambition. Smoking during pregnancy is still highlighted as a key modifiable risk factor for complications during pregnancy, such as miscarriage, premature births, low birth weights, stillbirths. You know, the CDOP report, which is the Child Death Overview Panel for the country, still has smoking in pregnancy is still the #1 risk factor for all child deaths under 1. So I feel like we still need to go harder and faster and kind of spread this, so we can obviously save more babies' lives. We implemented a comprehensive training programme for maternity staff, from our maternity support workers, our midwives, our obstetricians, our consultants. We really wanted to make this everybody's business. to help identify and refer smokers to dedicated maternity-led stop smoking services, which over time have been set up in each of the 7 maternities we've got in Greater Manchester. It's really allowed for that greater control. It's allowed for the services to have the autonomy. Oh, can I go back? Sorry. Yeah. And obviously just to make sure that we've got the service in-house so we can deal with that. And including that, we've included an evidence-based incentive scheme, which is given at different stages, but predominantly as soon as we get somebody in with us, we get them on a contract and we get them in. That's great, thank you. So this is our programme. So it's a jigsaw, and what lots of people do is trying to speak to us around what we do in Greater Manchester and trying to cherry pick and take pieces out of that. To say it's a whole system approach is absolutely key, and every little piece of these is absolutely integral to the other. So one does not work without the other. Obviously, CO monitoring, training our staff, ensuring that midwives can have a really good, very brief advice conversation, identifying every smoker through the power of CO has been absolutely phenomenal in increasing our engagement rates and ensuring that women are kind of reaching our services ready to quit. Urgency around referral is absolutely key. If it's important to you, it needs to be important to the woman. So the woman needs to hear it's got to be immediate, it's got to be now, we've got to get you ready. This is really detrimental to your pregnancy. I think when we look back at some of our data, we thought that approximately 60 women hadn't got to the second week of their 4-week quit because they had a pregnancy loss early in pregnancy. Now, if they'd been referred earlier, or we'd have got them in and we can get them quit, how many more of those babies would still be here today? Obviously, we've got our brilliant maternity stop smoking services. They're literally embedded within each trust. The specialist stop smoking leads, engage with all the midwives, engage with the band 3s and 4s who are doing the maternity stop smoking support. And we've made that a whole system approach within maternity services. We do risk perception. It's a really hard-hitting motivational interview, which occurs after the booking scan for those who are still smoking, and that's a really good teachable moment when a woman might have seen her baby on the scan for the first time. She's really excited and she's probably really motivated at that point to change her health behaviours to get the best outcomes for herself and her baby. So we really push hard at that conversation and ensure where possible we've got one of our fabulous maternity support workers kind of sat outside waiting to hold her hand and get her on board. Running alongside that has been incentives, and I think obviously we've had some great initiatives. Obviously Baby Clear in the Northeast have really led the way in this, in kind of how this model is working, to make sure that women are coming in and staying engaged. But obviously adding incentives to the mix is really adding another layer for us, and it's another kind of hook that has got women in and managed to get them remaining engaged with us. And what wraps around all this SAR data analysis, we've been really lucky in Greater Manchester in the last 12 months. We've developed a maternity stop smoking platform, which has allowed us to create a patient level kind of data record that runs through that whole of that woman's journey with our stop smoking services and really gives us that wider health intelligence. So who's engaging, who's quitting, how many of those are getting to smoke free at birth, what was our birth weights. We knew that our babies, for those who quit with us on the programme, were 200 grams heavier than those who hadn't. And obviously looking back on previous research, that's absolutely phenomenal for a baby at that time, especially if born a bit slightly early. Will benefit how that baby kind of thrives and develops in those early stages. Brill, thank you. So obviously our incentive journey, we make sure that we were really wanting to reach, as you say, Sue, all those really women who are going to need our support. So all those who are kind of under 20, living in areas of deprivation, and areas of high smoking prevalence. More often than not, they're living with the smokers. So for those who might decide to self-quit or quit right at the beginning of pregnancy, there's more risk that they're going to relapse throughout. And obviously those who've smoked throughout previous pregnancies as well. And we found through the risk perception is that women actually are hearing for the first time is that maybe the loss of a baby to them before might have been due to their smoking. So it's been a real challenge for many women as well to actually think about their smoking behaviour now it's impacted previously in their life and ongoing as well. We're really lucky in GM that obviously we have the support of Fran Franklin, who's going to join us later on, to really develop and really bring into the programme the incentives. And as soon as we get them, the staff are brilliant. They automatically tell the women about the scheme. We make sure we contract them. So we're getting them to sign on a dotted line to say that they want to engage with us and they want to be part of this. We also encourage them to bring a significant other along. And that means that could be a smoker, so it might be a partner, might be grandma, might be a friend, or it could be a non-smoker, but they're willing to be here to support the mum throughout the whole journey. And I think through the pandemic, that's been a real challenge, and lots of people living on their own. We're just beginning to see that those levels of support really increasing for women. But it's also increased the number of women who've had smoke-free homes, which has been phenomenal. But I think to bring somebody along in your journey with you when we know that's going to be a challenge is really key. But everything we do is all CO validated in Greater Manchester. We've been really lucky that we purchased carbon monoxide, individual carbon monoxide monitors. If you can all see my camera, if you can't, we can drop a link in the chat. And they've been fantastic in kind of empowering women to keep their quit going. So we see them weekly for the first 4 weeks, and they get £10 a week. And then we see them monthly, at least as a minimum every 4 weeks till the time of birth. And that's really essential, that we really keep, you know, the impetus going, and we see women and are not going to drop off after 12 weeks and risk that relapsing later in pregnancy when that baby needs all that oxygen and all those goodness and nutrients to grow, and not to be affected by the harms of carbon monoxide. So that's really key. And obviously we then try and see women up to 3 months postpartum, where we will continue that as well. We've also just completed a randomised controlled trial in the use of incentives in the post-birth period up to 12 months, and we'll probably have some of that results in 2023. The scheme is fabulous. It's really been uptaken really well. And obviously we do know women will relapse, but they have the opportunity to relapse and come back on through the scheme as well. So it's kind of like a two chances they get at actually coming on our scheme. Brilliant, thank you. So what's our success has been? So we've used it as our system-wide support, you know, so it runs alongside behavioural support, and we know that's more effective than just behavioural support and medication on its own. They're the really good hook that gets them in. The number of women who achieve a 4-week quit has increased by 272%. That's absolutely phenomenal. You know, I'm not sure anywhere else is seeing those numbers. All 4-week quits, like I say, are absolutely CO validated, which not only validates obviously our data, but it validates the quit, and the women really feel empowered by that. We've got the specialist maternity stop smoking service. The current 4-week quit rate is 75%. Same again, absolutely phenomenal. And probably for the majority of those, maybe 75%, we're managing to keep quit to birth, which again is absolutely amazing, isn't it? I think women want to do this, but they need support to do it. Significant number of increased smoke-free homes. You know, it's not only about the pregnancies, it's pregnancy and beyond, and how that will impact on the life course going forward. Significant others, you know, bringing people in, working together, getting that woman some peer support from a friend or a family. It is really encouraging to keep her on that journey. And obviously what we know is prior to the programme being launched, about 1 in 8 mothers were smoking at time of giving birth, and we've reduced that to 1 in 10. And we're hoping we'll take that even further as we kind of move forward in the pandemic, to the pandemic. Thank you. Just really briefly, I suppose there's our graph of where our smoking at time of delivery rates is. You can kind of see the preamble a little bit before we started the initiative, same as England, very much, you know, not real changes being undertaken. Obviously then the first probably 8 year to 18 months was obviously our implementation phase. We did that over three waves because obviously of the size of Greater Manchester. And I think the last kind of 12 months, we've really begun to see the, you know, the importance of our efforts. We've hit nearly our 1,000 smoke-free babies mark in Q4. So last year, and so I can't speak any highly for where we need to be and where we're going. Still away from the national ambition, you know, at 6%, but we know we're heading there in a really, you know, fast direction. Thank you. And obviously, this is just a really gorgeous case study from Tierney Rose, who really, you know, embraced our service and worked with her team. You know, she did use the vouchers. She found them, you know, that they were useful. She bought some extra things like nappies and things for her baby and treated herself. And I think the main takeaway from this is actually lots of women during the pandemic reported that they saved their vouchers up. They were using them for essentials like food, you know, to look after themselves and those activities of daily living. Whereas I think when I first started the scheme in 1819, women were saving up and they were spending them on. I remember one lady who'd come out of a domestic abuse relationship and saved her vouchers up and bought herself a pram for her baby because she'd never had anything new before and really wanted to treat her baby. Sorry, I've gone all goose pimpler. But I think the pandemic has really moved away from thinking that incentives are luxuries. Actually, what these have done is help these people who are kind of hit hardest by our health inequalities really kind of move through life and remain smoke-free. But feel free to have a look at that, and obviously you can click on the link there to our Making Smoking History site with the Tierney Rose's case study. Thank you.
Jane, that was great. Thank you so much. Lovely. And hopefully you'll be able to stay for a bit. And I can see some questions coming in the chat there, which would be quite interesting. So thank you very much. And just to move on to our next presentation from Wendy Joseph. Wendy has completed her master's degree at Sunderland University, and she's going to share some of her findings with us. So if I can hand over to you there, Wendy.
Yes, thank you. Welcome, everybody. Great to be here. My study looked at barriers to smoking cessation in lower socio-economic groups last year in Sunderland. I was very fortunate to have 11 heavy smokers who participated, 4 females, 7 male. These included 3 homeless people, 2 undertakers, a lorry driver, a single mother, a military veteran, and a person who was shielding, who's now unemployed. Their experiences were qualitatively interpreted using IPA, and I decided to inductively theme using the theoretical domains framework to add extra rigour. So why is this research important? Sunderland's Public Health England tobacco profile showed that the health inequality gap has worsened in the last 5 years, with hospital admission rates being the highest in England. 28.5% of lower SES individuals smoke in Sunderland compared to 25% in England. Particularly alarming, mixed ethnicity prevalence was 21% compared to 15% white. So what we do know is that some public health and health interventions can act to increase inequalities. So whilst we've seen a gradual reduction in prevalence over the last 50 years, particularly due to public health-driven tobacco control policies, lower SES smoking seems intractable. In Sunderland and Cumbria, people in the most deprived areas are more than twice as likely to die prematurely from cancer. They are also less likely to take part in screening for lung cancer. Current smoking cessation interventions, we know, depends upon high individual agency. However, the current models were developed over 20 years ago, and the last systematic review of health service interventions which act to reduce inequalities was published 23 years ago. Next slide, please. So what this research tells us, in this sample, all wanted to quit and all wished they had never started, and most had experienced deaths due to smoking of close family. Sadly, all had experienced multiple health worker interactions across services as being judgmental, negative and punitive when their smoking was raised, including within smoking cessation services. These memories strongly impacted on their sense of individual agency. Life stresses and unusually reported boredom, and I think that was because of the COVID situation, made people realise how strong boredom was a facilitator to their continued smoking. So that, together with lowered individual agency, even the contemplation of seeking help was fear-inducing. These smokers wanted accessible smoking cessation support, preferably through their GP, with perceived levels of increased support and an emotional connection to their GP practices, but they definitely wanted to focus on relapse prevention strategies and relapse support. It's very good to hear that most of them, bar one, were in favour of even stricter tobacco control policies. To end, I'd just like to play you a piece from a participant who's given consent to share this with you this morning. So if you could play the audio, that would be lovely. That's on the last slide, there it is.
Well, I always find them quite judgmental about my lifestyle, and they tend to focus just on that one negative activity that I engage in.
Right.
They don't see the other things that I do that are positive in my life. You know, like I work with older people. You know, I'm a nurse. I'm a very caring person. You know, I'm a caring grandmother. I'm a mother. I'm this, that, and the other. But they don't see the bigger picture. They just see this filthy smoker sitting in front of them.
Right.
But they don't think I have a value in any other aspect of my life, because they're just focusing on that one thing, because they're trained to focus on that one thing.
Right.
And they have their own, they come with their own agendas. Maybe they're ex-smokers, and it's a bit like religion. You change your religion and you become like fundamentalist. You come really into it.
Yeah.
Or they've never smoked. Do you know what I mean? Or they've never been a smoker, so they have no experience of of smoking, or how difficult to give up, or the reasons why you do it, or the reasons you give yourself to do it. They're there just purely to focus on, how can we get you to stop smoking? And that's all all the statistics, and they'll, and they'll use all this sort of scare tactics, which, quite honestly, all the smokers know anyway. But they can't overcome their craving. They can't overcome the craving to stop them. We know all these things.
Yeah.
My father died of a smoking related. He died of emphysema. So, I watched it. So, that, if anything should have deterred me, it would have been that. So, smoking cessation is, they're quite judgmental, I think. And some people are just quite abysmal,
Right. Thank you very much. And thank you for allowing me to be here today. Absolutely great. Thank you.
Thanks, Wendy. That's a really challenging
I always find
audio to listen to there. And I think it might well provoke some questions. So please do remember to pop any queries that you've got, or just thoughts even, into the chat that we can pick up later. So just moving on to the next presentation, which I'm just going to do a few introductory slides to. So this is around computer modelling, health behaviour, really, public health behaviour. So if I could have the next slide, please. Just to introduce the team, Teddy's here today, and Tian, and quite a few other people. Jane is here, and Fran, and a number of others. So it's great to see you all here. But basically, we're divided in a sense into three groups. So we've got the academic team led by myself, with Tian and Teddy doing the modelling, and Peter's giving us lots of backup. And Emma Giles was helping us before, but is on maternity leave at the moment. And so we've got a great advisory group as well, with both a mixture of academics like Jean Adams, and those who are commissioning and have provided, like Jane and Graham, Eugene, Rebecca. Abby is a service user, has come on as a maternity from the Maternity Voices Partnership. And we've also got an expert panel. There's a little bit of crossover there. But Fran works with Jane, and hopefully we'll hear from her a bit later as well in the discussions too. And Joanna, very experienced in stop smoking, and Louise is a public health midwife at South Tees, and Abby is helping us there as well. And our expert panel has done a number of questionnaires really about their experiences and the services they work in, and that sort of thing, to give us those types of details. And we are also hoping to do a bit more PPI work, but we had to change our plans. But now we're going to be doing more of a social media survey, hoping pregnant women who smoke will complete a survey for us. And Andy Graham has come on to do that just in the next couple of months. So that's quite an exciting development. So there are a number of other aspects to the project, but we're just going to, such as some literature reviewing and some other work around it. But we're just going to focus on the computer modelling today. If I could have the next slide, please. So just this idea, really, computer modelling, is it actually, can it be an alternative to trials sometimes? It can be an attractive option because it's cost effective, it's ethical, it's discreet, it's non-invasive. But I think there is a real question of, can it be done? How useful actually is it? And mathematical models are based on social interaction. In other words, networks of people and those interactions between them. And really, a lot of what this project is about is this a viable approach? So could I have the next slide, please? So we really want to know, can we identify which interactions motivate pregnant women who smoke to change their behaviour? So that's really what we're looking into. That's fine. Next one's fine. Thank you. So yes, just saw this the other day. It's a graph that was shared last week at a seminar organised by the new Office for Health Improvement and Disparities, that was previously PHE, showing the comparative effectiveness of a number of interventions that are part of that pathway that you will have heard Jane talking about earlier in terms of stop smoking, you know, services, the sort of support they give. Although I just noticed, you know, as Jane was talking, they've doing quite a lot of work in Greater Manchester around what we sort of call significant other, and that is not actually in this list. However, it's basically comparing the effectiveness of these different parts of the intervention. So although you would be having the basic standard that's recommended by NICE, which is on there, actually you can see from this graph, financial incentives are massively effective and in fact cost effective compared to the other types of parts of the intervention, if you like. So these results are actually based on Cochrane reviews and other high quality evidence that they pulled together for the purposes of this graph. And it showed this 10% increase in quit rate with financial incentives from basically 7 to 17%. So I think that just is part of the picture when we're talking about modelling financial incentives for this particular purpose. Could I have the next slide, please? So I think it's really about what provokes or nudges change. And one way is to introduce financial incentives or even any type of incentive possibly, but we're actually focusing on specifically financial incentives. And importantly, will this model be useful to commissioners and providers? The impact of incentives has been modelled before, but more recently, those who do computer modelling have begun to think about the opportunities for modelling this in health behaviour specifically, not just behaviour in general, but in health behaviour. So that's where we're up to. That's where this interest comes from, really. This project comes from. Could I have the next slide, please? So to test out if and how modelling could be used in health behaviour change, we've taken one population, the pregnant smokers, and are looking at the effect of giving them financial incentives to quit smoking. So if at this point I can just hand over to Teddy, that would be brilliant. Thank you. Off you go, Teddy.
Hello. Sorry. May I have the next slide, please? Next slide, please. Thank you. Right. So first of all, a little bit about me. I'm a PhD student and in computer science at Teesside. And I've done quite a lot of work on financial incentives in other areas other than healthcare. So it was really useful for me to start applying this, and then I could get some of my experience from before into this field. So part of my presentation will talk about the challenges of how you can get evolutionary game theory. So that's the picture on the left there is one of the fathers of this field, kind of John Maynard Smith. How you can get that work, that kind of theoretical mathematical framework into this practical field, and what are the challenges behind that. So I'll talk a bit about each development step that we had for the model, and then how the feedback with the expert group and the advisory group changed our view, at least the modeler's view, of what is important and what we should be focusing our work on. And then middle photo over there is this framework called NetLogo, which is what we've been using to model. And it's a very useful framework because it was first developed as this kind of education tool. So what that allows us is basically to get the model away to other people. So in this case, either the expert group or the advisory group, give them a small brief tutorial on how to use it and then let them play around with it. So actually, each time we complete a developmental phase of the model, we can easily have them play around with the parameters and see kind of what that does to the model. So what effect each and every mechanism that we introduce has on the model. So could I have the next slide, please? So this is what the first version of, well, version 1.1. So right after the first meeting with the advisory group, we developed this version of the model. And it looks very simple because it is very simple. So those little boxes on the left are parameters that you can play around with. And then that big square on the right is your world. So that's where you see basically each square is one individual and you can see what that individual is doing at that point. And in this version of the model, you have a very simple abstract interaction where an individual can only do 4 things, right? And these 4 things are based on this one timeline where you do not have any kind of timing or number of different investments. So you don't have many meetings and you don't have many financial incentives. It's just once, right? So let's just imagine for a second that you have this pregnant woman that comes to a meeting, decides whether to accept or reject an agreement. And in this case, it's kind of the contract that we're talking about to stop smoking. And then at the end, depending on their success, they either receive a financial incentive or do not. And so it's very, very simple. But even that framework, simple as it may be, allows us already to start introducing other mechanisms and to see what their effect is in this interaction. So if we have the next slide. So in this case, for example, we decided to introduce wealth inequality as a mechanism. And we introduced wealth inequality because it came up quite a lot when we talked about, especially with the advisory group and the expert group, this idea that not everyone is equal. And because not everyone is equal, then financial incentives could affect them in different ways. And the way we introduced this mechanism is basically comes straight from other literature in the field of evolutionary game theory. So not healthcare applications, but general applications as a whole, where you can play around, for example, with how the population is divided. In this case, we had an 80-20 split that kind of encompasses a whole range of different fields and applies quite well in different kind of parameter variables. And then this idea of homophily, which I won't go too much into the specifics of it, but it's this idea that birds of a feather flock together. So in other words, the poor are more likely to imitate the poor and the rich are more likely to imitate the rich. Of course, this is not like a black and white thing. So there is some variation here and there's some measure of randomness, but it's just a general measure to kind of give us that. And the important thing here is that we can play around with this variable. So we're not fixed in one way or the other. We can actually study for the whole range of parameter values. So we can study what happens when there is a lot of disparity between the rich and the poor. And we can also study what happens when you have low homophily or high homophily. And what that basically means is that no matter what kind of our demographic is or what our population is, we could play around with the parameters to target that specific scenario. So may I have the next slide? And just from that very initial model, we have these 2 preliminary results. So I won't talk too much about results. But from the first photo, we see this kind of disparity where if you look at what the initial incentive is versus what the final incentive is, we see a step in terms of initial incentive, where in effect you need a high enough initial incentive that you cover the logistic costs. So in other words, if you want this to succeed, or if you want it to have a higher chance of success, then you should increase your initial incentive so that people are more likely to attend these meetings. So in other words, you want to cover either the logistical costs, the cost of getting there, if, for example, you do not have the opportunity to just send maternity services directly at their location, but also the cost of opportunity. So if you imagine, for example, someone who is a bit, better state financially, then actually taking time from their workplace or any other considerant could actually impact them more. So that's that thing there. And then on the right side, you see what happens when you play around with this inequality and homophily. And what basically happens is if you have high inequality and low homophily, then it's quite similar to the baseline. Whereas if you have high inequality and high homophily, then almost nothing changes to the population as you see it. So in other words, if you have very rich individuals, then financial incentives will not do much either way you look at it. So in other words, if you give them more money, they will still keep on smoking. And if you give them less money, then it's going to be basically similar to baseline. So in other words, wealth inequality makes people unwilling to change their minds. Can I have the next slide? And following this kind of initial idea with the model, we decided, at least us, the modelers, decided to extend it to repeated interactions. So instead of having this one timeline where everything happens at once, basically, you just have one opportunity, we decided to allow for multiple meetings, multiple rounds of incentive, with the possibility for different sizes of incentive. So in other words, you could have, for example, more money being able to be distributed at the beginning of the pregnancy as opposed to the end. And then obviously that also allows people to fall through in the middle. So for example, either because of a negative test, a CO test, as we discussed before, or for any other reason, they could reject the agreement basically and fail to continue. And if we look at the literature, I have some examples in the literature over there, then you may notice there's quite a lot of examples of gaming or how to be more successful in these kind of theoretical games. And we see this in kind of Robert Axelrod's well-known computer tournaments, where the most successful strategy was tit for tat, which, as the name would suggest, basically just does whatever the other person did to you. And there were quite a few problems with this approach, as we'll see in a second. So if I have the next slide. So game theory is not always the answer. And I think this is one of the main limitations of computer modelers when we do talk about this, is that feedback from the expert group and the advisor group was very, very important. And at this stage of development, we realized that going this repeated interactions route is probably not the priority. Why? Well, because gaming doesn't really happen. So even if it does happen, it's not widespread enough that it's really a consideration that you have to build your model on it. And then even if it does happen, there are some ethical considerations to consider. So if you do start designing your whole incentive scheme based on the idea that people will try to exploit the system, then you start to forget about the important things. And in this case, the important things are promoting engagement, so promoting pregnant women going to these meetings with healthcare professionals, and other things, right? So for example, seeing how we can avoid relapse and many other considerations. So may I have the next slide? So then, because we decided to step away from repeated interactions, we then looked at other ways we could develop, so other mechanisms we could introduce into the model to make it at the same time more realistic and more interesting. but also to help us identify ways in which we can improve financial incentives. And that's why we decided to look at network dynamics. So on the left there, we have the initial world where, if you remember, it was the square grid. Everyone has 4 neighbors. So it's very typeset, very regular. And in many cases that could be realistic, but not always. And then on the right here, we have what we call a scale-free network, which is a more realistic type of network, or rather it seems to be more realistic in certain scenarios, such as the internet, for example, or citation networks. Unfortunately, we do not have very good data about healthcare, but if we do consider that, for example, pregnant women are on social media or on other such platforms, then we can start seeing some similarities, because we know social media networks are much more complex than these regular square networks. And so it gives us a motivation to use these scale-free networks. And as you can imagine, in scale-free networks, you have these hubs, you have these individuals that are less connected than others, you have another type of inequality in effect, and that allows you to introduce more complex financial incentives, for example. So you might want, for example, to target individuals that are very well connected in their communities, or any such sort of idea where you want more complex behavior. So next slide, please. And another mechanism we decided to introduce is this idea of significant others. So I think Sue touched upon it briefly earlier, and then we and Jane as well touched on this idea of significant others. And I would like to point out that significant others are probably a very important, even more so than the literature might suggest, very important place to target, because it can go both ways, right? So not only do you have the benefit of 2 people quitting together, if you do get them to quit together, but if one of them is still smoking, then that could be really harmful to the other person trying to quit. So that's where the image with people lighting up their cigarettes from the same cigarette kind of comes up, is that it's much harder for someone to quit smoking if their significant other is still smoking. And likewise, if both of them quit together, there might be some positive feedback over there, but not necessarily as much as we would expect. So that's why it's important to introduce both ideas at the same time. And can I have the next slide, please? And could you play the video? So thank you. So this is the model as it stands currently. So you see on the right there, we have a scale-free network, as we discussed earlier. Obviously, it's much smaller and doesn't look as complex as the one we saw before, but that also the limitations behind kind of visualizing these huge networks are quite daunting. But on the left, you see not much has changed, actually. So we've added quite a few mechanisms, we've taken some away, and that's intentional. So we don't want to add everything at once to the point where we can't understand the effect of different mechanisms. So it's super important to add things one at a time, as it may be. And we've also added this idea of bias factor, where we can actually model the effect of significant others, and then later on we can decide to extend our financial incentives to the significant others as well. In that case, we will be able to invest money to change their behavior as well. So just as an idea of what the model looks like now, and if you imagine if you had a bit of free time, you could probably just play around with the parameters and see, for example, what happens when we have high wealth inequality, what happens when everyone has a significant other and their opinion matters a whole lot, for example. What happens when no one has a significant other? What happens when you increase the size of your incentives, either the final incentive or the initial one? And all these other things that you can play around with. And as computer models, we can just sweep across the whole parameter values and see basically what happens in every scenario. And that will give us an idea of how we can motivate these decisions that we have, these decisions of how to change our different incentives. And then final slide, please. And then some future directions just to motivate the discussion that we'll have later. And I encourage you to send questions about this and to discuss about this is, first of all, we would like to introduce repeated interactions, but in a smarter way. So not exactly a focus on these like complex strategies, but more so a focus on how can we vary this timing. So in other words, when should we invest and how often? Variable endowment sizes. So if we consider engagement to be very, very important, and as we saw in the first slide, the initial incentive is quite important, then how can we redesign our incentives so we basically cover this cost of participation and we actually motivate people to come to these meetings? Exploiting network characteristics. So what happens if, for example, you target hubs in the community, so people who are very well connected, and then different testing paradigms. So that basically tells us, okay, what happens if you have very strict testing, or what happens when you have lenient testing? What happens if you forgive people if they relapse, or if you never forgive people if you relapse? So these are all things that we can study with this kind of computer model, and it will give us a better idea of what would be effective in the real world. And then finally, just financial incentives versus engagement. So this is kind of a huge discussion, and there's already quite a lot of literature about it, which is actually more important, just the money of the finance, so the financial incentives as a financial thing, or is it the engagement of people meeting these healthcare professionals and having the same, for example, the same healthcare professional they're speaking to, be that their GP or someone else? So there's always that considerant, and then as computer modelers, we can study maybe both. So not only how we can make financial incentives more appealing and more cost effective, but also how we can improve engagement at the same time. So then you basically have the opportunity of making everyone happy, as it may be. So yeah, thank you very much for your time. And I think I went a bit over the time, but hopefully that's not a problem. And yeah, looking forward to your questions later on in the discussion groups. Thank you.
Thanks, Teddy. That was great, and hopefully we'll provoke some good questions as well. So do put those in the chat. It can be quite a controversial subject as well. So yeah, so thanks very much. And actually, you're dead on time, I think. So well done. And just moving on to the next presentation from Angela. Angela's a senior lecturer at Northumbria University, and she's going to tell us about a study she took part in to introduce a stop smoking service into a hospital. So over to you, Angela.
Thank you, Sue. So yeah, I'm presenting on behalf of the whole team on understanding the implementation of the Cure Stop Smoking program. And today I'll focus on the qualitative study from this project. The project was commissioned and funded by Public Health England, that no longer exists, but for the purpose of this presentation, we're acknowledging Public Health England. Next slide, please. Okay, so the key idea behind the Cure module is that hospitalization provides a unique opportunity to engage smokers, to initiate conversations about cessation, and to facilitate appropriate follow-up and support. The main idea behind or the inspiration for the Cure module was the Ottawa model in Canada that found positive effects of a similar intervention to increase smoking abstinence at 6 months. So the positive outcomes from the Ottawa model led to the development of the Conversation, Understand, Replace Experts and Evidence-Based Treatments program that has recently been piloted within the NHS Trust in Northwest of England. Next slide, please. So the Cure program aims to increase awareness about the medicalisation of tobacco dependence and support clinicians in offering smoking cessation for all inpatient inpatient smokers. So this is really an important kind of foundation for the program, and it kind of links with what we were talking, what Wendy was mentioning before, that stop seeing the smokers as a lifestyle option, but more as a tobacco dependence issue. So similar to the Ottawa model, CURE aims to improve smoking outcomes by providing a combination of pharmacotherapy as well as behavioral support to patients. And you can see the chart here on the screen that goes through what happens as part of the CURE module intervention. He also provides post-discharge support at 2, 4, and 12 weeks. So as I said, the CURE model was initially piloted within Greater Manchester. And it started initially late October or late 2018 and ran until March 2019. And after this initial pilot, it was fully implemented into service. And we also know that it is currently in various stages of rollout across the region. Next slide, please. So just before I go into the project itself, I want to highlight that our main focus here was on the implementation of the service within the hospital and not so much on the patient-facing intervention. So as you'll see, the findings do relate more to within the implementation contents, and we won't provide as much information about the intervention itself. So the main aim of our project was to describe the core elements of the CURE implementation strategy, particularly the activities directed at promoting behavior change in health care professionals and also within the organizational context. Next slide, please. So the project included several work packages, and as I said before, today I'm going to focus on the stakeholder interviews. So the interviews aim at identifying barriers and facilitators of the implementation of the service, and also link these barriers and facilitators to theoretical frameworks that are known to influence behavior. Next slide, please. And so we work with the project management team at Greater Manchester to identify potential participants. And because of the fact that we are based in the northeast of England, we conducted the interviews via telephone. And then we've done some in-depth analysis of the participant transcripts and extracted data about the factors that influence implementation, and finally producing a report about barriers and facilitators of implementation. Next slide, please. So we had 10 participants that took part in the interviews, 7 from management or leadership and 3 deliverers. This project actually took place in early 2020, so at the same time as the first lockdown happened, and this led to the fact that we had to stop data collection, hence only having 10 participants. Next slide, please. So we had 8 overarching areas of influence, or themes, if you like, that were identified in the stakeholder interviews. And these themes are related to a framework that we use for analysis called the theoretical domain framework. The framework itself compiles evidence-based factors known to influence behavior change. So I'll just briefly go through them, because then I'm going to summarize the findings related to those. So environmental context and resources relates to any circumstance of an individual situation or environment that either facilitates or hinders the implementation of CURE. The goals are outcomes that an individual wants to achieve. Professional role and identity relates to a set of behaviors or personal qualities of an individual in a workplace. Social influence is any interpersonal factors that can cause an individual to change their thoughts, feelings, or behavior. Reinforcement relates to a dependent relationship between a behavior and an incentive. Beliefs about consequences are beliefs about the outcomes of implementing cure. Skills that can be either physical or psychological skills to acquire through practice, and knowledge is an awareness of the existence of something, in this case of cure guidance. Next slide, please. So when we look at the findings, we identify both barriers, facilitators, and also some themes that could be labeled as mixed barrier and facilitator. And within the environmental context and resource, we found that establishing standardized discharge pathways was seen as a barrier, and I'm going to highlight this in the next slide. Can we move on to the next slide, please? Sorry, the one after. So one of the key things that we found in the results was this idea that it is important for the implementation strategy to really establish a standardized discharge pathway and integration with primary care and external organizations. This seemed to be the main struggle within the implementation strategy. And most of the interviews highlighted this. The other issue was also nursing staff highlighting common barriers to delivery, and this is actually something that we see a lot of times in similar research that within healthcare professionals. So time pressures and the environment itself can hinder the delivery of specific services. Next slide, please. The other issue was also adequate staffing resources and access to cure-related knowledge and training and funding for all stages of support. But this is in relation to this, there were mixed views regarding whether this helped or hindered the implementation. Broadly, these factors often facilitated delivery within the core hospital team, but sometimes pose barriers for the wider healthcare staff. Next slide, please. Across participants, the most commonly identified facilitator was this idea of the importance of peer leadership, and we kept seeing this in the interviews that the clinical lead was actually someone really engaging and was really good at encouraging staff commitment. And I think a lot of the interviewees put down this as one of the key facilitators to how well the implementation went. The other facilitator was also the leadership in planning and oversight of the implementation was also highlighted as something that helped the implementation. Next slide, please. And finally, for the delivery staff, they also highlighted the intrinsic reward of cure involvement and beliefs surrounding the positive impact that it had on the patient, so the personalized support. And this was seen by the delivery staff as a facilitator of cure delivery. Next slide, please. In terms of the recommendations that we provided to Public Health England, we mentioned this idea of identifying champions to implement such service to encourage staff engagement and culture change. So clinical champions seem particularly effective in engaging and motivating staff members across all levels and could be influential in changing unhelpful cultural beliefs. Patient choice was also something highlighted. So focus on patient choice and shared decision-making within cure should also be emphasized when aiming to engage stakeholders. Here, I haven't mentioned, but in the training, this was very obvious in all the training materials that they had different products available to patients, and they were really keen to make sure that healthcare professionals were comfortable with all types of products. So they could recommend and allow for patient choice at this level. And finally, something that I already mentioned before was to also work on the discharge pathways. Although CURE is a secondary care-led service, increased integration within the wider healthcare environment has the potential to maximize impact. Next slide, please. So this study provided evidence about current practice in the pilot study that could inform the implementation strategy improvement and also the implementation of an NHS-funded tobacco dependence treatment and policy in secondary care in England. The recommendations provided may optimize and inform future implementation strategies, and we ran a series of workshops to actually go through the recommendations that we've written with stakeholders to make sure they were actionable and could be integrated in future implementation strategies. But finally, we also concluded that there's potential for more small-scale qualitative evaluation involving either the national rollout, but also the other sites, to see if the barriers and facilitators that we found in this study are also relevant in other sites or at the national rollout level. Next slide, please. Well, thank you so much for listening. If you want to find out a little bit more about the qualitative study, this has been published and the link is on the slide. Thank you.
Thank you, Angela. That was great. So I think it's been good to hear about a number of initiatives, really, often mentioning Greater Manchester, I have to say, but also recognising some of the work we did in the Northeast, going back a few years as well, and of course has continued. So although I think Wendy's presentation there definitely offered some real challenge, at the same time, I think we can see there's a lot of work being done to actually develop stop smoking services, whether that's into hospitals, whether it's with specific populations such as pregnant women, and still much to be done, I think. So I think we're just about to start our Q&A session. Peter, I don't know if you want to highlight any particular questions in the chat.
Thanks, Sue. Yeah, absolutely. There's some questions that come in that I will highlight, but please feel free to put your hand up if you've got your own questions that you want to ask the speaker or your reflections you would like to share. We got about 10 minutes for this, but if there's more questions remaining, we can maybe pick them up in the breakout rooms after the break. So one of the questions that came in, Sue, and this I think for Jane particularly, so I would invite the presentation, the speakers to put their camera on so we can see them and they can respond to your questions. But this is a question for Jane, I think, and it's a question that I asked by Stephen Carter about how close are we to having a nationally mandated SIP incentive scheme, and what will this mean for existing locally developed schemes in terms of consistency and equality of offer? That's quite a question, Jane, but if you wouldn't mind having a go at what your thinking is.
Do you know what? And I would absolutely love to give you an answer. You know, I think we've seen the success of our GM scheme, and obviously in schemes like other undertaken in the Northeast, and we've kind of gone with that similar pathway to them. As regards nationally, we know that obviously Jo Churchill was the previous, was she the Under Minister for Health? I'll apologise because I'm not really sure on her title. Was really for incentives used in pregnancy, and we know that there's you know it's being talked about in the tobacco plan going forward, and I suppose it predominantly goes on to what the spending review comes out with, what monies will be made available. You know, it's also looking at systems. So as an, you know, we've got 44 developing ICSs, and how can money be not necessarily new monies, but also how money can be distributed differently to allow us to try incentive schemes, or even looking at those with more disproportionately affected by smoking during pregnancy. So there's lots of ways to look at it. I think I would love a national scheme. I would love, you know, that ability and equitability for everybody to have the same. We know that babies don't have a choice if women smoke, and we know that they become more at risk of stillbirth and small for dates and being admitted to hospital. You know, we did an evaluation piece last year in GM where we did a case note audit, and we found that probably we spend about £15 million on full maternity price points every year for those who smoke during pregnancy. I think it's absolutely key that we begin to look at, I suppose, how the introduction of incentives can be outweighed by the kind of return on investment we can see with getting people to quit. So although, you know, I would love a national scheme, and being in my national post, I can obviously help drive some of that. But I think those questions sometimes are a lot out of my hands, and with a lot more people sat up the food chain. I think what we have to do is just keep providing supportive evidence around what's being delivered, keep bringing that together. You know, obviously we work with Joe Locker and Martin Wilmore from OHID as they are now, you know, and they're really pushing for changes to tobacco legislation to support those who are smoking during pregnancy. So we've just got to keep working hard and showing the data, like we've said before, to really show us what we can achieve.
Thanks, Jane. It's a great call to action, and hopefully this event will contribute in a small way towards that. There are also some questions for Teddy. First, a question of clarification about is this model a form of microsimulation, but then sort of a follow-up question around sort of how can this modeling be used to inform a suitable level and frequency of incentive in order to influence behavior. So does it suggest that incentives should be graded, means tested by income and deprivation? Would you mind picking that up, Teddy? If you...
Sure. So both of them really good questions. Well, all three of them really good questions. First of all, is this a form of microsimulation? It's very close to it. So in some ways, it could be considered microsimulation, but usually speaking, microsimulation focuses a lot on individual behaviors, whereas our model looks more at the behaviors of the overall population. So depending on where your focus might be, especially when you collect results and where you're actually targeting things, it could be a microsimulation. But I think for our use case, it's more of a general wide scale simulation. And then second and third questions, very interesting. So first of all, how can this modeling be used to inform a suitable level and frequency of incentives? At this moment, it's not such a powerful model to do that. But later on, after we introduce repeated interactions, and I wanted to touch upon this point in the presentation, we can actually calibrate the model with real world data. So we can calibrate both the baseline, and then we can take an existing incentive scheme and then calibrate it using that data. And afterwards, we can have a really good idea of, first of all, what the suitable levels are and frequency, and then we can start playing around with it more. So in other words, once we have it calibrated, we can tell quite easily how big our magnitude of incentive could be and should be in order to change these things. So that's the key thing here, is that we need to calibrate it, and then afterwards we can play around both with the frequency and with the amounts of incentives. And then does it suggest they should be graded or means tested by income or deprivation? I would say no. I mean, beyond the obvious, yeah, our population of pregnant smokers does not care that much if we don't treat them all equally, and they don't care about equity and all sorts of these things. It's just, you know, artificial agents. But yeah, we could test out many different ways in which incentives could be graded. We aren't so far, and I don't think we will in the future either. I think it's more important to consider everyone equally, and then see how best we can maximize our efficiency using those metrics. So in other words, I assume there is some answer to how you can maximize incentives without being selective about who you target. And I would say being selective about who you target does have some ethical concerns there. So if you say, for example, okay, we'll only target incentives if you're a super important member of your community, or if you're in huge levels of deprivation, I don't think it's that easy. I think we should care about everyone equally. Hope that answers the questions.
Thanks, Terry. Very helpful and great reflections that hopefully inform some of the discussions also in the breakout rooms later. I just at this point wanted to go to Angela because there were some questions for her as well. I mean, one was around sort of question of clarification. So when you mention NRT, does that mean, or do you include e-cigarettes and vaping in that? And then sort of a question about maybe a link with the presentation that Jane was doing, which is about sorry, I've got the wrong question. The presentation that Wendy was doing. So do you think that the cure has been able to address some of the issues raised by Wendy's study? So particularly when you look at those with high nicotine dependency, does cure sort of help to address some of those concerns raised by heavy smokers? So is that something you could maybe reflect on, Angela?
Sure. So in regards to vaping, as far as I understand, it wasn't part of the offer of the intervention, part of the cure service. However, the implementation strategy did have something about a vaping policy within hospital, and actually a couple of stakeholders highlighted that needed to be further worked on, because it wasn't they didn't see it as a full implemented strategy, and they made suggestions for making it broader and providing facilities for vaping. So even though it wasn't part, it was actually something highlighted by the stakeholders as important to actually build on next in future implementation strategies. Now regarding Wendy's presentation, I think cure overall as this idea of integrating smoking cessation as part of within secondary care, and the aim of raising awareness about the medicalization of tobacco dependence kind of tries to change the paradigm of viewing smoking as a lifestyle choice, and more so as a dependence issue. So I think that could help in what Wendy was mentioning, and what the user highlighted as a judgmental kind of perspective from the healthcare professional. But I guess that will depend on future training and how this is fully implemented. Maybe you might need, I think I've seen someone also suggested that maybe there's something to be integrated in training overall to kind of shift this view in regards to stop smoking services.
Thanks, Angela. That's very helpful. And maybe relates to sort of another comment that was posted in the chat recently from Kerry, sort of reflecting on Wendy's audio clip. So maybe Wendy might like to reflect on this, but sort of saying that it was very insightful after all these years of supporting smokers to quit, that their experience still feels judgmental or not taking into account their wider lived experience. So the question is, can we put some thought to skills for professionals around motivational interviewing, making every contact count, which are all well established, but key is the positive interaction with the professional. So Wendy, I was wondering if you could offer some reflections into the skills that professionals need to sort of support people with their lived experience of heavy smoking.
Yes, would you like that now, or?
Yeah, just some initial reflections.
I was extremely surprised at the level of vehemence from the group, and most of them didn't. Well, they all, bar two people, knew each other. I was very, very surprised, and I also felt really sad that there was only one of them who was a little bit of a younger participant in his early 30s. That all of them had experienced very close family and friends' deaths. But what they found was that almost at every stage of a health interaction, whether that was at the dentist or going to the chiropodist, they were asked a series of questions. What we've got to remember is somebody from a lower socioeconomic background, that's my background, is that each time you try to interact in education or work or in a health interactions, you do unfortunately have this perceived idea of what your message of communication, how that's going to be received. So I think there is definitely part of that. It's definitely a cumulative effect. But hearing from them that, and I did probe that, you know, what about within the smoking cessation services? And they felt that was even worse, because they thought, you know, I've put my hand up, I'm here, I want to be here. But then the response was, especially at relapse stage, was, right, okay, you're obviously not serious about this, or you're not ready. So, you know, try again when you are ready, or maybe next year. And then no support, no information, no advice. And to be honest, it was really shocking that practically all of them, bar two, the thought of even going to smoking cessation services filled them with absolute dread. And it was almost like, oh, well, you know, we're going to be punished again. We have to go through this again. You know, so it started them off with this kind of, this individual agency of, you know, I'm useless, I can't do this. So yes, it was very difficult to hear.
No, that's helpful. So it is looking particularly at how big a relapse stage, maybe how you make people feel they're more sort of welcome or supported in the issues that they experience, and sort of looking at how you build that relationship with professionals. That's something we'll touch upon in the breakout rooms as well. At this point, I'm worried that we've all been on it for more than an hour now, so it's time for a little break. So at this point, I would like to thank all the speakers for their great presentations and answering the questions as best as they can, which is much appreciated. There's more questions in the chat, and we will try to pick them up after the meeting where possible, or maybe in the breakout rooms if time. At this stage, we'll break up for 5 minutes so you can get a little stretch, a cup of coffee, go to the toilet if you need to. I certainly do. And then we'll be back here at, it's now 19, so say 25 past 11, and then we'll start some of the breakout rooms. The idea is that we take some of the ideas from the presentations forward into a more sort of intimate discussion where we look at some of the solutions for barriers to smoking cessations for pregnant women. So please don't go away, stay for the interactive bit, and we look forward to seeing you in 5 minutes. Thank you very much.
Okay, so is everybody back with us? Hopefully,
yep, I think we're
everybody
all back,
managed
so
the tech. It was quite fun in the end in our group, and I hope that everybody else had a good experience and some good discussion there as well. So Peter, let me hand over to you to just, if you can, maybe pick up some highlights. And we know that one of the reasons we tried to use the Jamboard is so that we can capture more of the discussion. So it will be there to reflect back on.
Absolutely. So
let me hand it over to you now.
Thank you. So thanks everyone for joining the breakout discussions. And I've tried to hop around the rooms a bit and see some very lively discussions. So thanks for participating in that, and thanks for bearing with us with the Jamboards. That was sort of a first venture into Jamboards for infused meetings. So hopefully they're helpful, and we will continue to keep them open so you can add comments after the meetings. If you got some brilliant brainwaves in the middle of the night, feel free to add them, and we will share these afterwards so you can have a look at them. What I sort of picked up from the different Jamboards was, because we asked you two questions in the sense of what sort of, how can we incentivize people to stop smoking, what could service offer, and sort of how do social interactions link into this, and what should we focus on. And sort of what I got from someone, and I can't do justice to all the post-it notes, but some of the key messages were around sort of getting people into the room. Attendance is really key, and that's where a lot of the incentivizing and service should focus on, and making that sort of first meeting a really positive engagement by building trust, avoid confrontation, and really sort of try to sort of make that start a very good start, and incentivize that. And that relates to sort of Teddy's early presentation, that first incentive should be high and cover various things, including the transport costs. There were some comments made about maybe we can do that by, or we can reduce those costs by having more virtual meetings or offer those, which are welcome and good to look into, but also has some risks in terms of digital exclusion that they need to be aware of. And a discussion around the significant others, basically people said that a lot of them are important. It's difficult to pick one in the sense that decisions should be with the pregnant smoker themselves. They should be able to express which is their significant other, and therefore who should be incentivized to support them in their journey. And also that lived experience is really important for engaging with pregnant women through the services. So the more we get people with lived experience supporting women in that stop smoking journey, the better. There's much more richness of detail in there, and I won't be able to do it all justice, but these are some of the things I picked up. And we will look at the Jamboards in much more detail to sort of inform sort of how we can increase the model and what Teddy talks about, what other parameters can be asked to make it a more realistic model to help inform planning and commissioning decisions. So at this point, I'm going to hand back to Sue, who will take us through sort of the close of this event. But really thank you for joining the discussion today and making all your contributions, which is much appreciated. Is that all right, Sue? Does that
yeah, absolutely.
give some
I think
thought?
you almost said the next slide for me. We can just have the next slide. So yeah, a big thank you to everybody's contribution, particularly our speakers, and of course our backup team, or I should say behind the scenes team at Fuse. And thank you for coming, everybody. I think we've got one more slide, I think. Just to remind people of some future Fuse events coming up. One around parental substance abuse and young people's resilience, and another around COVID-19 pandemic and healthy aging. So just you can go to the website for more information on those, and would encourage you to go if they're relevant to you. But just to say, I hope you found it really interesting. I know I have. I've had a good time, and I hope you have too. And it's been useful to you, that you have learned some stuff, and it'll be able to use that in your work, whether that's research or whether that's on the front line or commissioning, providing. So I just want to thank you very much, and the event will be online soon. So thank you to everyone who contributed. So thanks very much. Bye.